Okay, moving on to cardio. We'll finish up the last two lectures of cardio. We have heart failure, cardiomyopathies, and we have just a short lecture on pulmonary hypertension. And I'm recording this stuff, so don't worry. So our objectives for today, acronym list. So keep this in mind as we're going through. The big ones is don't confuse these ones. We did in pathophys, the HFpEF and HFrEF. There are other classifications with that as far as mid-range or preserved, but obviously we looked at reduced or keeping it where it is. Or the first, these ones we did already, these ones are new. HOCM we talked about, idiopathic hypertrophic subaortic stenosis. What is that really talking about? What part of the heart is getting thickened? What part of the ventricle? What? Septum. This is septal hypertrophy. This is dealing with the septum. MRA, mineralocorticoid receptor antagonist. So what kind of drugs are we dealing with? Classes of drugs? Mineralocorticoid. Aldosterone-related drugs. PND, paroxysmal nocturnal dyspnea. SLG2I, or these sodium glucose cotransporter 2 inhibitors. Just a class of drugs you get with Dr. Wood, and then obviously lifestyle changes. So definition of heart failure, the heart can't pump adequately to match the demand of the body. So systolic failure or the HFrEF, can't meet the demand, so you have heart failure. Inability to fill the heart due to abnormally high pressures, that is diastolic failure. So remember, the systolic ones is the squeeze going forward. The diastolic ones are the filling problems. They don't fill properly. And you can have biventricular failure where both of them will fail. Classifications, HFrEF, meaning EF is less than 40%. The improved EF means that they were at one point below 40%, but you gave them medication, you treated them appropriately, and you checked their measurement again, and now it went up to over 40. So that's a heart failure with improved ejection fraction because the medicine that you put them on worked. Mid-range just means the EF is staying in that mid-range, still 41 to 49, and preserved EF usually above 50%. What is our normal EF again? Well, it's right there, so 55 to 65. It was right there, so right there. Epidemiology, 8 million people, 500,000 new cases a year. Primary DRG. DRG is a diagnosis related group. It's a coding term, if any of you worked in billing before. It's a coding term. That means that when you, in the summer 2, you guys will take a healthcare dynamics class. And in that class, you guys will take one lecture about coding and billing. How do you know what to bill? You gotta get paid for what you're doing. And the way you get paid is by being as descriptive as possible. So there are all these diagnosis-related groups just dealing with coding. Also monitored by CMS for reimbursement. So they look at heart failure rates. One of the big things they look at is heart failure. That's why you have to be very descriptive as far as how you classify it. You can't just diagnose someone and they have heart failure. That doesn't mean anything. You have to be descriptive. What side is it? Left-sided heart failure. Okay, we know what side, but what's going on? Is it improved ejection fraction? Is it reduced? Is it preserved ejection fraction? So you have to be very descriptive. Is the patient acute or are they chronic? Are they have chronic CHF and they're fine? Or do they eat a bag of potato chips, put them in a fluid overload, now they're coming to see you because they're in CHF and they have problems breathing? That's an acute exacerbation of the CHF. So you have to be very descriptive as far as how you write your notes. 35% of patients with mild to moderate heart failure will die within 4 years. Most common causes is CAD and the hypertension. Some other causes, here's your alcohol abuse, diabetes. We learned about diabetes before. Remember, it has macrovascular complications. as well as the microvascular. This is a macrovascular dealing with the coronary arteries. And obviously, all new treatments have been shown to improve survival. So that's why it's very important that you treat these patients very, very well. The most common one is going to be the systolic dysfunction, the reduced ejection fraction. They've had heart attacks. They reduce the function of the heart, so the muscle is not going to work as well anymore. So we don't squeeze as well. We have increased afterload. Heart's got more stress on the heart, has to overcome that. Bless you. In heart failure with preserved ejection fraction, this is your diastolic dysfunction. And remember, when we deal with diastolic dysfunction, just remember filling problems. They don't fill right. Whereas systolic heart failure, they don't squeeze right. Diastolic, they don't fill right. In that gray zone, current knowledge is still limited, but again, mixed heart failure, the treatment is mostly going to be the same. So what causes the heart to have heart failure to lead to this issue? Heart attack, just intrinsic myocardial damage, ischemia, heart muscle lost its function. It's not going to squeeze as well, therefore your stroke volume goes down. Abnormal load on the left ventricle. This will also lead to heart failure. We've all gone through that with pathophys, how heart failure leads to hypertension. Or sorry, how hypertension leads to heart failure. We went through all that cascade and everything. And the last thing is any neurohormonal effects, the RAS system. So we talked about renal artery stenosis, these pre-renal causes for the renin-angiotensin system to be activated. What hyperaldosteronin that we talked about yesterday will cause renin to go up? Was it a volume problem or was it an aldosterone problem? Volume problem, right? So that's secondary hyperaldosteronism, where the kidneys don't get enough blood, so they think there's low pressure in the system. So what does the kidney do? Activates the RAS system. What's going to happen to the blood volume? Going to go up. What's going to happen to your blood pressure? Going to go up. All that extra blood pressure has its exertion on the heart, because the heart has to squeeze all that blood going through, and it can fatigue and weaken the heart. So these are three causes that lead to heart failure causing. Here again, just showing that renin comes from the kidney, angiotensinogen comes from the liver, which will cleave it and cause ACE to form. This conversion, where does ACE come from? From the lungs, and then we get, finally at the end, we get our aldosterone being released. So this is just the RAS cascade in another way of looking at it. Clinical features, medical history, when they come in with heart failure. Find out about dyspnea on exertion. How far can they walk before they start getting fatigued and winded? Orthopnea. This is an important one here. Ask how many pillows they sleep with at night. Because the more the heart failure is advanced, they have to sit up to allow blood to pool and get out. When they lay down flat, all the blood pools in the neck and they have problems. They can't breathe. So how many pillows? Some of them will just sleep in a recliner all the time because they can't lay flat. So they'll just be in a recliner. PND, paroxysmal nocturnal dyspnea, ask about any edema, fatigue, and so forth. Other symptoms that can happen along with heart failure: impaired cognition, urinary habit changes, a nocturnal cough. Weight gain is a big one. You want to find out from your patients what their dry weight is. When they go into CHF, they have a fluid overload. They have too much volume. They can't get rid of the excess weight. So they gain weight. They'll gain like 20 pounds. But all that is just water. It's fluid. So you diurese them, the fluid, they pee like crazy, and the fluid comes out. But weight gain. If you know what their dry weight is, and if they gain 10 pounds overnight, this patient will know, hey, I gained a lot of weight. This is not normal. This must be fluid. And they know they're going into CHF that way. And again, just some more symptoms, looking at different parts with that. Physical exam findings. Very important to differentiate left-sided versus the right side. This should be a review from pathophys. We did it a lot. Remember, with left-sided heart failure, the blood gets backed up where? The lungs. So you get dyspnea, orthopnea, PND because the blood is being congested in the lungs, causing those problems. Physical findings, sweating, tachycardia, pulmonary rails, allowed P2 because of the volume. The right side of the heart now has to pump against all that extra pressure in the pulmonary system. May have an S3 gallop, may or may not have S4. Here's right-sided, peripheral edema, right upper quadrant discomfort. Why do they have that? Liver. You got ascites in the third spacing in the abdominal cavity, it pushes things up. So right-sided failure, where does the blood back up? The body. So they get peripheral edema, lower extremities. Those are right-sided failure issues. Now remember, what is the most common cause for right-sided failure? Left-sided, so that's why some people will have signs of both. Swelling in the legs, problems breathing, they have a combination because the left-sided caused the right-sided failure. So here is your orthopnea. How many pillows are they using? Here is your edema. That is pitting edema. Do you see they put their thumb there and the thumb still remains? That is tissue swelling. It's like a sponge. When we learned about pretibial mixed edema in thyroid in the last lecture, they have thickened skin so they won't pit like those do. This is all water. If you squeeze it, you can feel the water like a sponge being pushed out when you squeeze those people's legs. Bottom left, this is your ascites. Again, right upper quadrant pain. You can see all that fluid in there. When you do on your abdominal exam, that fluid wave, and everyone's like, I don't know what I'm doing. It's because they don't have all that fluid there. If you tap that belly, you'll see the wave from all the fluid going across the belly. That's the fluid wave. And then the last thing, here's your JVD. And you can see how well popped that vein is to accommodate all that excess blood. So that's JVD. Recommended diagnostic test in all patients with suspected chronic heart failure. Get a BNP. BNP is a marker that we use. It does not, we don't use it as like a marker like TSH does. TSH, we want that to be within a range. BNP, we just want to be reduced. So if you come in with acute heart failure and your BNP is 500, our goal is to get it lower than that and get it lower and lower and lower. That's all, and it's just a consequence of diuresing that patient. The BNP will come down naturally. 12 lead EKG. Everyone gets a 12 lead EKG. Why? Because we know CHF. What's the main reason for CHF? Heart disease, right? Ischemia. So let's get a 12 lead EKG, see what's doing with the heart. Transthoracic echo. Everyone gets an echo. Why do we want an echo in a heart failure patient? Ejection fraction. We got to know what that EF is. So echo is going to tell us that. Chest radiography. Why do you want to do that? Cardiomegaly. Look for pulmonary congestion. Curly B lines, right? All those little fun things. Yes? So whenever those questions come up, in your mind, always think, we always go from least invasive to most invasive. So in this case, would I order a cardiac catheterization on this person right off the bat? No. That's very invasive. There's other things I can do first. What I can do, I can get blood work. Everyone's going to get blood work when they come in. That's very easy to do. 12 lead EKG, any patient coming in, as soon as they come in, they're going to get a 12 lead EKG automatically. Now, when you see them, you will look at the chart. Now, let's say this patient had an echocardiogram a month ago, and it showed weakened heart then. Do I want to repeat an echo now? Not necessarily. I don't have to. If they're having new symptoms, then I would reorder an echo and get it done again. Chest x-ray, very easy to do. When we talk about next best step, that's more like MRI, CT, ultrasound. Ultrasound, very hardly invasive. Just you guys did all that in lab yesterday. Just jelly on your chest and then the probe and you're done. You don't feel anything. So they're easy to do. So echo, most of these things even can be done in an office setting. If they come in to see you and you're working in a cardiology office, you're going to have all this stuff. You can do it in office and see what's going on and go from there.
So would you say that these are all of like the first?
Yes, you would order all of these things for heart failure.
Okay.
So, yeah.
Sorry. So let's say like for the exam, we wouldn't have like as options to choose between all of these.
Yeah, it'll be more distinct.
Okay.
Whenever you see in certain things, they'll say this is the gold standard for that. Whenever you see stuff in notes about gold standards, those are usually like first line that you're going to be doing for testing for that reason. Routine blood work for other comorbidities like diabetes, lipids, check all those things to see what is going on with the body. You can do an iron status if you think they're anemia that's causing them to go into heart failure. So the labs are kind of more like, what do you think is going on else with this patient that you want to grab? When it comes to these tests, now I only worked in cardiology as far as like in an office, and I worked hospital medicine, so it was a little bit different, but you know, we're GI too. Remember, GI only has like 4 complaints. When you see a patient, you're already going to know ahead of time what they're here for. So if I know I'm going to see a patient and they're here for, oh, they had chest pain 2 days ago, I know already in my head for my plan, I know I'm already going to get an echo, EKG, x-ray in this patient. The plan is already done before I even go into the room because I want to check these things. So it's like, what am I going to look for? If they have palpitations, what would you want to add in there? They have Holter monitor, right? Because they have palpitations. Let's see what's going on. If they're having chest pain, I also want to do a stress test to see what's going on there. So in your mind, you already have an idea like what you would want to do for these patients before you go see them. So those are all things you would want to do for that. Other diagnostic, okay, x-ray, interstitial marking, EKG. Now, on the EKG, there is no typical EKG diagnostic criteria for heart failure. But you guys know heart failure. What are some of the changes that happens to the heart with heart failure? Enlarged, hypertrophy. So what do you think you would see on an EKG with someone with heart failure? LVH, right? They can have LVH. You think hypertension, but again, they have heart failure. We know that hypertension leads to heart failure uncontrolled, or untreated. So there's nothing on an EKG itself. They're heart failure, they're not heart failure. But what's it going to do? It's going to confirm to me that they have left ventricular hypertrophy due to untreated hypertension for many years. And I can see that on an EKG. So it's just confirmatory. Lab studies, get your cardiac enzymes, make sure they're not spilling anything, undergoing any current ischemic event. BNP will be elevated with heart failure. A normal BNP level we want to get is around 100. So when they come in routinely, if they're coming in, their BNP is normally, like when they come in with CHF, it's like 800. Well, let's say they're coming in now, they're fluid overloaded, but their BNP is like, let's say it's like only 100 or 200. What other cause that's non-cardiac related will cause volume overload? Renal failure, right? That's where you start to differentiate when they come in with CHF or they're fluid overloaded. Is this due to their heart not pumping effectively? Or is it due to the kidneys not filtering out enough fluid? Where's the problem? If you do a BNP and it's relatively normal, it's probably renal. You could also do your renal, your BMP, and your creatinine and BUN are going to be elevated. That tells you right there the kidneys are stressed. So start differentiating between the two. CBC, chemistry, BMP, get your liver, and again, TSH. Why TSH? Well, what's the link between TSH and heart failure? But what causes it? Remember, this is thyroid now. Hyperactive thyroid. It's that thyroid storm, hyperthyroidism. Severe hyperthyroidism, untreated, can lead to heart failure and death. So if they're coming in with heart failure, we don't know why. Let's check the thyroid, make sure the thyroid's okay, because we know the thyroid can lead to heart failure, mainly with those thyroid storms. We get that dump of thyroid hormone goes into the system. So echo, we want to look at any wall motion abnormalities. The heart has to squeeze. Is the wall moving the way it does? The cardiologist will tell you all this in an echo report. They'll say the wall motion abnormalities, some hypokinesis, so part of the wall doesn't move. Why wouldn't a wall of the heart not move? It's dead. Tissue died because of a heart attack. When it dies off, the muscle properties are gone and it's not going to squeeze. Any structural heart disease, anything doing with the valves, anything there that we need to be worried about that would impede flow, causing issues, looking at our valve, and obviously the EF is the key. What does the ejection fraction show? And the echo report from the cardiologist will tell you everything. You are allowed to order the echo. You say, I want to get an echo for this reason, for CHF. The order gets made, the echo team will come down, they'll do the ultrasound, and whoever the cardiologist on call that day is, they'll read it and submit the report. And then throughout the day, you'll check updates to see if the report was printed, and then you'll know what the EF is. Usually it's pretty fast. You'll get it done really fast in the ER. So EF again. So with heart failure, you can see how big this chamber got, the thickness of this wall, very thin compared to the other one. This wall here is not going to move as well, so you have that hypokinesis. It's not going to move as well. Remember, when the heart squeezes, the walls come in, and they squeeze against the fulcrum, which is the septum. When we're this wide, it's hard for these walls to get in, and they're floppy, and they don't move right. So this is with heart failure. Functional classification of heart failure. I think you guys did this already in part 1, right? Heart failure, type 1, 2, 3, 4. New York Heart Association. Okay. So functional class, there's none for that high risk. But class 1, asymptomatic, they have heart failure, but they have no symptoms from it. They're very well controlled on their medications, and they have no issues. Class 2, symptomatic with moderate exertion. So they go to a theme park, walking around, they get short of breath, they have to sit down and relax. But they're doing some sort of still strenuous activity. They go to the mall, they're still walking. 3 is when they have it with ADLs. Washing dishes after standing up for 5 minutes, washing dishes, they get out of breath and short of breath. Those are simple activities, your ADLs. And then 4 is just while they're sitting there at rest, they can't breathe. These are the people who need that sit up in a chair, mounted up on pillows to help with the breathing. This is the American College of Cardiology and the American Heart Association stages. Stage A, high risk for heart failure without structural heart disease. So this is your hypertension, your coronary artery disease. Due to these deleterious processes over time, causes the heart failure to happen. But there's nothing structurally there that causes the issue. In B, we do have structural heart disease, but no symptoms of heart failure. So there is disease there. Structurally, there's issues, but they're not having any symptoms. C, they do have structural heart disease, and they either have prior or current symptoms of heart failure. So prior means it's chronic. Current means it's acute, meaning they're having acute symptoms of heart failure right now when they're coming here to see me. Or they have chronic heart failure, they're coming to see me in the office just for a 6-month follow-up. Weight is good, they're at their dry weight, whatever that is. They're not having any breathing problems, there's no swelling going on, blood pressure is controlled, heart rate is controlled, those patients are okay. And D is obviously refractory heart failure, meaning meds don't help. When they're refractory, they're not responding to the medications anymore because the heart is damaged too much. At this point, there are different interventions you can do to help with that heart failure. One is you put a device in, a defibrillator that has biventricular, so it has left ventricle and the right ventricle. What they do is they poke a little hole in the septum, and that allows the probe to go across. Or sometimes what they'll do is they'll go in the coronary vein that drains into the right atrium, and they'll go in that vein and it'll wrap around the back of the heart, and they'll leave the probe, the catheter for the pacemaker in the vein. This way it can still have its effects. But you can it's called cardio resynchronization therapy. You have the defibrillator on both sides and makes the heart beat at the same time. So it helps with functioning of that. Other tests, nuclear med studies, a MUGA. A MUGA scan is a nuclear test, but it just looks for EF. That's all it's going to tell you. And how it does it is it tags the nuclear isotopes. You put the blood back into the person. You see how much blood goes in that's coded, and you see what comes out. And you can calculate what the ejection fraction is. That's all it's going to tell you. The echo will tell you everything else with the heart, with the EF. But sometimes they're faster with a MUGA. Ejection fraction, know what that is. Cardiac catheterization, rarely used as a primary assessment. So cardiac catheterization is not a first-line therapy. Now, if they have complex hemodynamics, like they're not supporting their pressures, they need a lot of support with medicine to keep their blood pressure up. You probably may want to cath them to see what the pressures are showing especially on the right side of the heart. See what those pressures are. If anyone's going for, let's say you do an echo and they have severe aortic stenosis, and that's what caused their heart failure. So the echo tells you how bad the aortic valve is. It tells you the aortic valve area, all that fun stuff. In order to repair that valve, the majority of the time they open you up to repair the valve. Well, I'm already opening you up. I want to make sure that your vessels are okay too. So I will do a cardiac catheterization to see how your vessels are. Because you're already open. If you have some vessel disease and a valve, I'll just repair all of it at once. So that's when you do a cardiac catheterization to see how the vessels are doing before a valve issue. Because a valve, you can find that out on echo. It won't tell you anything about the coronary arteries. The catheterization will. Here's your x-ray. Here is our spinal column. Here is that part. Should that be there? Does the right side of the heart, should it cross over that midline? No. Not really. But this one does. Why? Because they have heart failure and they have right ventricular enlargement as well. So the whole heart got big. What else is there? This is pretty much normal. So heart failure on x-ray, those curly lines. Curly B lines are short, horizontal lines. The curly A lines are long, straight lines from the hilum to the pleura. This is caused by edema in the perilymphatic connective tissue. This is reversible with pulmonary edema, irreversible with pneumoconiosis, or lymphangitic carcinoma. So curly A lines are long, the B lines are short. And these are usually perpendicular lines at the lung periphery due to fluid in the interlobular septa. Transient and pulmonary edema, but these curly B lines can become permanent if they have fibrosis, sarcoid, or carcinoma. And there's also curly C lines, reticular network overlapping the B lines, occasionally seen with interstitial pulmonary edema. So these are the different lines. Here are the B lines, the A lines. I'm not very good at x-rays. But there again, perpendicular, the A lines are long, so forth. Okay. And for more examples, again, of the different tracks. Again, whenever you see these things, pulmonary congestion, swelling in the pulmonary, overload fluid, pulmonary edema, something's going on that's causing these lines to show up. This is a pleural effusion. Remember, with pleural effusions, you lose the the costophrenic angle. Yeah. So the blunting, you can see it on the other side, but they don't have it on the right. Okay, so they blunt it right there. This is all fluid right there. Oh. And you have a nice costophrenic angle on the left. So this is a right-sided pleural effusion. Everyone see that, right-sided pleural effusion? Okay. So how do we treat our heart failure patients? And also they have cardiac rehab for these patients. So the treatment depends on, one, is this acute or chronic? So chronic patients are usually on steady medications. If they're acute exacerbation, we'll give them some IV medications in the hospital to help with the diuresis. Is it emergent, non-emergent? What kind of heart failure do they have? Is it systolic? Is it diastolic failure? What do they have? Risk stratification for LVAD. LVAD is a left ventricular assist device. It's a fake heart. It's external. It's got a battery and it continuously turns, and it allows the circulation for your heart to work. These are people, they'll get this while they're waiting for a heart transplant, or they can be on it for life. And the last thing is cardiac rehab. So if you ever worked like the YMCA, a lot of them will do like cardiac rehab in different rooms. They get put on telemetry, and they go on an exercise and they get treated. So goals of treatment. Number one, always, what's the underlying cause? Why are they here? What put them in heart failure? Why are they here right now? Eliminate any precipitating factors. Manage the symptoms with our New York Heart Association classification. Watch for that neurohormonal response via first-line pharmacotherapy. So all those things that happen with heart failure, we have to watch those things and we treat it with medications. And improve our long-term survival with cardiac rehab and supportive services. So this is our goal for treatment. Always remember lifestyle changes, low salt DASH diet, weight control, some activity if possible. You have to always deal with lifestyle modification with your patients. Always bring it up. Walk until they get tired. Low salt DASH diet. Next time you're in Publix, go down the seasoning aisle. You'll see all these Mrs. Dash spices. None of them have salt. So it helps with these patients, they don't go into fluid overload with the excess salt. So most of the guidelines are all based on systolic dysfunction. So goals of therapy, reduce the morbidity. What are they going to die of? Reduce the symptoms, improve quality of life, functional status. Can they do their ADLs again? Decrease the rate of hospitalization. If you discharge a patient with CHF and they come back in the hospital in 2 weeks, you're going to get dinged for that. Because why is the patient coming back in 2 weeks? What did you do? Like, did you take care of them? Did you give them appropriate patient education? Well, they have to follow that education, of course. I'm not saying you're not going to get fired or anything. It's not you getting dinged. It's like your practice or the hospital gets dinged with these readmissions. Within 30 days, why are you coming back within 30 days? You shouldn't be back in the hospital. So they look at readmission rates. And obviously reduce mortality. You don't want to be in a hospital. Hospitals are sick places. The longer you're in the hospital, the longer your risk of other infections goes up. So when you're working in a hospital or as a hospitalist as a PA, your mindset should be, how can I get you out of this hospital as fast as possible? In a safe way, of course, but make sure you want to get them out. So again, the treatment is focused on the cause of the heart failure and any associated conditions. Monitor them, preventive care, coordinate care with other types of modalities. One of the things we'll start doing as you go through your time here are what's called IPE, interprofessional education, where you will work with other people from NOVA and other schools that all deal with patient care. If you assign them to do cardiac rehabilitation, well, there's someone that's going to have to do the cardiac rehabilitation for them. So you may want to find out what's going on. So you coordinate plans. You say, hey, I'm sending someone over for you. What are you going to be doing? And then You guys all discuss all that. We used to do stuff with speech language pathology when they were here. They would have a Parkinson's group once a month, and we would go there and talk with them when we learned about Parkinson's and stuff like that. So again, interprofessional education, you will be working with other fields, not just PAs or MDs. All the therapies will be there as well. Fluid restriction is also very important because obviously you don't want to overload them with fluid. Everything you drink goes into the bloodstream. So we want to reduce that so they don't get fluid overloaded. They're very, heart failure patients are very sensitive to changes in fluid. That's why you gotta be careful with like salt. If they eat a big bag of chips, all that salt is gonna raise their blood volume. The heart can't handle all that extra volume and it stresses out real fast now. And you go right into acute heart failure. So that's what we're talking about with all that stuff. Diastolic heart failure, largely neutral results concerning pharmacological therapy. These are filling issues. So with this case, most of it is related to associated conditions. Controlling the blood pressure, control the AFib if they have it, and any specific symptoms like edema, obviously you can just diurese. And you can get rid of the extra fluid. So just more of the symptoms that they're having with diastolic heart failure. So this is the important part. This is the acute setting. They ate a bag of chips, they're in fluid overload, heart failure, now they're coming to the ER to see you. So remember LMNOP. L, Lasix, IV loop diuretics first. We got to get this fluid off of them. Lasix works fast. So that's one thing we give. Morphine, if they have pain. Remember, when they go into heart failure, they're going to have a ton of catecholamines being released. That lowers the heart rate, which decreases oxygen demand. So that's when we have heart failure, we get a surge of catecholamines. We want to give the pain, the morphine, which blunts the catecholamines, which makes the heart work easier. So morphine makes the heart work easier, so it doesn't get stressed out as much. Nitrates, venodilator. So nitric oxide, remember nitric oxide is the most potent vasodilator we have. So we give nitric oxide, nitrates, isosorbide dinitrate, isosorbide mononitrate, a whole bunch of different nitrates. But vasodilation decreases preload. What's that going to do to the stroke volume or the stress on the heart? Decreases it. Less stretch, less forceful contraction. The heart will relax with a reduced preload. The O is for oxygen if necessary. And the P is for the positioning. If they're having problems breathing, don't lay them flat. Bring up their body, the head, so they can breathe easier. So that's the positioning. So LMNOP, Lasix to get the fluid off, morphine to reduce the O2 demand and control any pain if they're having it, nitrates to help with the preload, oxygen if necessary, and then positioning of the patient. Fantastic 4 meds of chronic relief. We have the ARNIs are a new class of drugs. These are angiotensin receptors and then norepinephrine inhibitors. This is your Entresto. It's a combination drug of like an ACE and an ARB together. They get together. The SGL2 inhibitors, those are the sodium ones that inhibit that. Beta blockers are very important as well. And anticoagulation or rate control is controlling the rate as well. So drugs, ACEs and ARBs, lisinopril, vasodilatory effect. So it's going to lower BP and reduce the afterload, right? If we decrease systemic vascular resistance, afterload decreases and the heart squeezes easier. We want the heart to squeeze better. So we have to give medicines that allow it to squeeze better. Also shown, these ACEs and ARBs help with hemodynamics, reduce symptoms of fatigue. What else is important? Reduce circulating levels of angiotensin II and aldosterone. May reduce plasma norepi and vasopressin levels as well. So giving ACEs or an ARBs helps improve the prognosis. So everyone has to be on an ACE or an ARB. If the patient can't have an ACE, what would be a reason that you would not give a patient an ACE inhibitor? angioedema, the dry coughing. If they had those problems before, they can't go on an ACE again. Give them an ARB. The effect is the same. Angiotensinogen receptor and then neprilysin inhibitors, sacubitril and valsartan. This is your Entresto. First in the class, new drug and class. It's a whole new class of drugs. Why are combo drugs better? Compliance. Compliance with the patient. You're right. It's still helping with different symptoms, but it's easier for a patient to remember to take one pill than 2 pills. So that's why the combo ones help a lot. So best in, reduced ejection fraction patients. Blocks the neprilysin, thus preventing natriuretic peptide breakdown. Why is that important?
That helps with the BNP.
It helps with the BNP, brings it down so that you reduce. Remember, what does natriuretic peptide do also? Natriuresis, to get rid of the sodium out of the urine that will bring water along with it. The longer this can stick around, the longer your body can naturally diurese yourself, or natriurese, because we're doing with sodium. And avoid if they have, ACE inhibitor issues in the past. If the patient is on an ACE inhibitor and you want to put them on Entresto, you need a washout phase of 2 days between the end of the ACE and the start of this new drug. So you just have them stop the ACE on Monday, and then on like Wednesday or Thursday, they can start the Entresto, and they'll be fine. Mineralocorticoid receptor antagonists. These are your MRAs. This is where your spironolactone comes in. Spironolactone is a receptor antagonist for the mineralocorticoid receptor. Where is the mineralocorticoid receptor? It's in the notes, but obviously in the kidneys. What part? Distal convoluted tubule, common collecting duct, very, very last little bit. That's where the aldosterone receptors are. This drug goes in there and it blocks it. So it can't do anything. So if we block aldosterone, where's the water going to go? Out. So that's why spironolactone is the diuretic that we give them normally for routine chronic heart failure. If you see a patient, they're going to be on lisinopril, spironolactone, usually a beta blocker, we'll get to that in a second, and a baby aspirin. Those are the 4 medications that they're going to be on. Beta blocker helps with the catecholamine response. ACE inhibitors help with the afterload reduction, and so on and so forth. So every drug you give has a reason that you're giving it for in heart failure. Yes?
When would we give sacubitril?
Heart failure. It's to treat a heart failure. It's one of the drugs. Instead of giving an ACE by itself, we can give Entresto, which is the ACE and the neprilysin inhibitor.
How would we know to pick the ACE over that one?
So when you guys go on rotations, your first week at any new rotation, find out what drugs they use. They'll only use 10. So in this case, whatever the cardiologist likes, they will prescribe. Usually ACEs, because one of the other things, ACEs are generic. Entresto, I don't think is generic yet. I think there's like a 7-year time frame before a drug has to go generic. Or what does the drug company do? They change the formula, and they can keep their patent on their drug. So you'll see like a drug will be twice a day dose. And they'll come up with a new extended release dose where it's only once a day. And they can keep the drug private because they changed the dose. So inhibit sodium resorption in the collecting duct of the kidneys so water stays in the nephron and we pee it out. Use in systolic heart failure. Careful lab monitoring. These are potassium-sparing diuretics. So remember, aldosterone, sodium and water resorption, potassium excretion. But now we're blocking the aldosterone receptor. So sodium and water are excreted. Potassium is brought back in. So they have a risk of hyperkalemia. That's why these are called potassium-sparing medicine or potassium-sparing diuretics, because they are going to increase potassium. So you must make sure you check BMPs to see what's going on with the potassium. Beta blockers. The only ones that we give are metoprolol, Toprol XL, carvedilol, Coreg, which is the main one, and bisoprolol. Obviously, they're all beta blockers, so they end in olol. But Coreg, carvedilol, is the big one that we give with heart failure. Primarily used for reductive effect on heart rate, although, again, this is not the only important mechanism. It influences our RAS system of the kidneys, which causes a decrease in renin secretion. We decrease renin, what hormone is not going to come out at the end? Aldosterone. We don't want aldosterone. So it helps with these patients. Reduces heart oxygen demand by lowering extracellular volume, increasing oxygen carrying capacity of the blood. Beta blockers also sympatholytic activities. It's going to block the sympathetic system, reduce heart rate, and thereby increasing the ejection fraction despite the initial reduction in systolic function or ejection fraction. In trials, beta blockers have shown to reduce the absolute risk of death by 4.5% over a 13-month visit. Also, here I said before, hospital visits and hospitalizations were also reduced. We don't want to readmit a patient with heart failure when you just send them home. It means you didn't treat them well enough, or you didn't adequately cover them or get them in control before they left. So they help with chronic AF. This is important. Do not use beta blockers in the acute phase patient, only with the chronic. So remember, we have that mnemonic for acute exacerbation of CHF. LMNOP. There's no B there. There's no beta blocker. So you don't give it for acute. So remember, you don't give beta blocker for acute. These SGLT2 inhibitors, first line treatment again. And these, what happens with the body, shows increased weight loss, sympathetic nervous system inhibition. We don't want the sympathetic nervous system going crazy in heart failure. Increases the demand for oxygen, increases the heart rate, the workload on the heart, and it makes the heart failure worse. So increased erythropoietin helps reduce the severity. The vasculature, these type of drugs reduce inflammation, reduces arterial pressure, eventually getting to improved vascular function, which helps reduce the severity of your heart failure. So they work better. What is this? What does that last one say? RIM. Oh, mostly renal. Kidneys increase diuresis. Remember our natriuresis. Why does natriuresis go up in heart failure? What hormones also going up in heart failure? BNP, ANP, the natriuretic peptides go up. So obviously, we are going to have increased natriuresis, reduced blood glucose through glycosuria. So we're able to get rid of the glucose out of the bloodstream, get it into the kidneys and get rid of it. Inhibition of our sodium hydrogen channels in the nephron, improved energy metabolism, reduced hyperuricemia. What's that going to help reduce? Gout. Very good. Also helps with heart failure. And then finally, the heart. These SGLT2I inhibitors help improve energy metabolism. And if the energy metabolism is working better, the heart will work easier as well. Improved cardiac remodeling. That's important. What happens to the heart during heart failure over time? It enlarges and thickens. Heart remodeling says the thickness can be reduced and the heart can try and get back to a normal size and shape. If you have a dilated cardiomyopathy where it's floppy, that's not going to go back to normal. But if it's thickened, that can be reduced back to normal. And these drugs help with all that. Second line and third line drugs. So everything we learned right at the beginning was the first line. They have to be on one of those classes. Beta blocker, ACE, diuretic, and one of these SGLT2Is. They'll be on one of those. One of each category. So they'll be on 4 medications, plus probably a baby aspirin. Yes?
What do you do with the SGLT, the last one
Uh-huh.
you were talking about? Because aren't they like really expensive too?
They probably are, but I mean, again, some of them have like coupons you can get like for the manufacturer's coupons, and they help with like offsetting the costs of some of these medications. Some of them may not. The SGL2s are a newer class,
Right.
so they may not be used as much, but they need to be on the other 3 for sure. Digoxin. We mentioned digoxin a little bit. Digoxin helps with AV node conduction. Controversial with use in heart failure. It's not very, very big. You won't see digoxin very much with heart failure patients. Some morbidity benefit, but no mortality. So it's not going to reduce their death, but it may reduce other problems from happening as well. Helps with increased availability of intracellular calcium, myocardial and the conduction system, with consequent increased inotropy, increased automaticity, reduced conduction velocity. So primarily with patients with CHF and AFib. So if they have CHF and they have AFib, then you can give digoxin. It helps slow the conduction through the AV nodes so you don't get those fast heart rates. Otherwise, don't give digoxin. If they have AFib, then you can give it. Goal of therapy, again, always improve quality of life. Reduce the symptoms that they're having. Reduce hospitalizations. Best effect if their EF is less than 25% and their New York Heart Association 3 or 4. So they're having symptoms with ADLs and at rest. They get the best benefit from digoxin. Yes?
On the previous slides when we were going over first lines,
Mhm.
or like the ACEs,
Mhm.
The MRIs, are you prescribing all of
All
those
of
at once? Okay,
They get everything.
okay, gotcha.
Any other question? Yes?
Sorry, I thought you said they get one
Of each category. Yeah, so all 4. They get 4 drugs.
Oh, by category, I thought you meant like first, second.
No. These are the categories. Beta blockers is the category. They get one of these drugs. They'll be on spironolactone.
So then the second lines are backups for if they can't get one of
Well, the second line is, one of them is digoxin, but that's only really good if they have AFib. That's when you would add it. Vasodilators. Okay, so nitrates for venous dilators. Hydralazine is for an arterial dilator. Some of them will combine nitrates and hydralazine. An example for this is Natricor. Thank you. Natricor is usually an IV drug given in an ICU for like severely fluid overloaded patients. Yes?
Sorry, back to the first line management.
Mhm.
With the 4 categories, do you start with a specific one or do you?
All 4 at once. Yeah, I go on all 4. But it's basically a recombinant BNP, so obviously it's going to help with natriuresis and diuresis to get the fluid off. So Natricor is a second or third line drug. It's going to help with vasodilation and relaxes smooth muscle. Refractory cases. These are the people, you give them all this medicine, they're still not compensating. You can give a beta agonist like dobutamine. So now we're dealing with a beta agonist. So we're going to activate the beta system, not block it. So dobutamine, direct acting agent, primary result, stimulation of beta 1 receptors of the heart, increased contractility and cardiac output. So these are people who have heart failure is so bad, the heart pump itself is so weak. This is going to help support them get their blood pressure back up again because the heart is not pumping. Then you have to give the really strong stuff. This is where the dobutamine comes into play. Dobutamine holiday, patients feel better after the dobutamine infusion and tend to become asymptomatic going on a holiday. So like, they want to go away, they do a dobutamine infusion, and then for the next week or two, they'll be better if they want to go away somewhere. But be careful because high doses of dobutamine will have a pressor effect on the vessels, but a low dose only on the heart. So it affects just the heart. But if you get too high of a dose of dobutamine, then it causes vessel changes. Additional considerations for refractory heart failure. Here's your amiodarone. Here's your ICD, which has specific criteria. Again, you have to have low EF for that one. Cardiac resynchronization therapy. So there's our vessels. And what happens is we have the pacemaker probe. One comes into here, and the other one comes across and wedges itself right there. So now we have pacemaker lines in the left side and the right side of the heart. And the little device up at the top has the program, and it'll make sure the heart beats together. So what heart condition that you guys have all learned about already, you see it on EKG, where because you have this conduction problem, the left and the right side of the heart don't beat together. Bundle branch blocks. Someone said block. Bundle branch blocks. When you have a left bundle branch block, what side is going to depolarize first? The right side. So the right side of the heart will squeeze just slightly before the left side will because of the way it's set up. In a right bundle branch block, the left side gets activated first, so the left side will squeeze just slightly before the other one does. But remember I said, for effective squeeze, both sides of the heart come in and they squeeze against a fixed septum. So if you're, like when you're squeezing toothpaste in the morning, you squeeze from both sides and the toothpaste comes out. If you squeeze from one side, the whole toothpaste moves over, and you squeeze the other side, then it comes right back in. Nothing comes out. Same thing here. The left and the right side don't work together anymore. They don't squeeze properly, and you have reduced ejection fraction. Cardiac resynchronization therapy tells both sides of the heart to squeeze together. It bypasses the whole bundle branch block, and we get resynchronization of the ventricles. And their EF improves. LVAD is that device for people whose heart is just not squeezing anymore. The heart fatigued out. It's not going to recover. They need a heart transplant. This kind of assists them. Cardiac valve replacement. What valve is synonymous with heart failures? Main one, aortic. So you replace the aortic valve, and it can hopefully help with a heart failure. Non-invasive positive pressure ventilation. This is all breathing with respiration. Cardiac rehab. Palliative hospice care. That's if they're refractory to all types of treatments, and you bring palliative care, which is death and dying, and hospice and all that stuff. And you'll deal with this in legal ethics. That pops up a couple times with palliative care. But that's obviously last stage. So CPAP device for heart failure. This is that, positive pressure ventilation. So CPAP, continuous positive airway pressure, is what CPAP stands for. And helps the alveoli diffuse oxygen, helps get O2 back into the blood. Increases the resistance of gas flow during exhalation, providing resistance to the exiting airflow of the gas. So when you try and breathe out, that positive pressure keeps your alveoli inflated. It helps, it reduces your expiration so the air stays in your lungs longer. Can lessen shortness of breath experienced by patients, improving performance of the heart. Ventilation improves and airway secretions are removed, improving oxygenation and CO2 removal. And helps with intrathoracic pressure, causing an increase in cardiac output. So it helps reduce the need for heart failure patients to be intubated or placed on a ventilator. So if you just put them on a CPAP, they can take it on and off. Some people, your grandparents probably have one. They sleep with that at night or whatever. You can take it on and off. Same thing with the heart failure patients. It helps them with that. Other devices for class 3 and 4. Here's your pacemaker, defibrillator. Biventricular pacer, again, is both right ventricular and left ventricular are involved. Biventricular ICD, they're the same thing, just the AICD is going to shock you. The pacemaker will not. So So when it comes down to, just remember, pacemaker is just rhythm control. Defibrillator will shock you for VTAC, VFib. LVAD is a bridge to cardiac transplantation for EF less than 25, so really, really low ejection fractions. 3 or more hospital admissions in 1 year due to heart failure because, again, they're not being compensated. Dependent on inotropic support, keeping that heart squeezing very well. Very high pulmonary wedge pressures. Low systolic blood pressure. Cardiac index drops. O2 sat in the venous side. Right ventricular dysfunction. And these are the contraindications to LVAD. Any anatomical issues? Can they even get the device inside the chest to do it? Very small surface area of the body. They're very small framed. The LVADs don't work very well. If they have a primary right ventricular dysfunction, don't give them an LVAD. Remember, it's a left ventricular assist device. If they have a restrictive cardiomyopathy, LVADs don't work very well. Any ventricular arrhythmia, NSVT, stuff like that. Coagulopathies, social cultural issues, and obviously if they're on hemodialysis, you can't give them an LVAD either. Healthcare disparities. There are differences based off race and ethnicity. Age-adjusted heart failure-related cardiovascular disease deaths and hospitalization rates. So when they took everything across the board, same heart failure symptoms, this and that, it kept everything the same. Race became a problem where high incidence for black patients, young black men 2.5-fold, and women, then white women and men as far as disparities in heart failure outcomes. In black patients who have persistently symptomatic, hydralazine and your nitrates help. Okay, remember the isosorbide dinitrate was a second-line drug, those nitrates. But in black patients, if they don't do all the other drugs, you can give them the nitrates and it helps. In addition, if despite a maximally tolerated beta blocker, how do we know you're tolerating a beta blocker? Heart rate and blood pressure. Just look at mainly your heart rate, but blood pressure affects as well. If your heart rate is in the 50s, that beta blocker is too strong. What we're saying here is that if you are on a maximally tolerated beta blocker dose, anyone know what the dose range is for metoprolol? 25, 50, 100 for the most part. 100 is like the maximum you can take. So if you're already taking 100 milligrams of metoprolol every day and your heart rate is still in the 80s, you can't go any higher on metoprolol because you're already maxed out, but your heart rate is still in the 80s. That is not a good sign. So you can give ivabradine. I've never heard that one before. Can be considered in those patients. Language-specific treatment instructions. Okay, you're giving instructions if your native language is English and they're not English speakers. Things will be lost in translation. Most everything medical is always printed in English and Spanish. If you need other languages in the hospital, they're like blue phones that are your translator phones, and they'll help you with all that. Cardiac rehab. Get them set up for cardiac rehab. Get them used to walking on a treadmill again, getting some movement going. Activity will help. That heart rate variability, heart rate going up and down will help them. Cardiac rehab, and you set them up for it. There are self-directed apps they can do at home with it, and there are programs for cardiac rehab as well. Your cardiac support team, obviously the doctor, you have your heart failure nurse, physical therapist is involved, dietitians in there, pharmacist, social work. You see all the different fields of medicine that are involved just with treating a patient with heart failure. So the interprofessional education, and everyone's got to do it. Let's take a break. Come back. What time is it now? 10:55. Come out at 11:05. Okay, so let's finish up. We got cardiomyopathies and then a little bit of pulmonary hypertension. So, we learned about cardiomyopathies and pathophys. There are basically three of them: the dilated, restrictive, and hypertrophic. Remember all those? Bringing back memories. So, cardiomyopathies are just a group of diseases that affect heart muscle, making it harder for the heart to pump blood. Any people across any lifespan, they can be asymptomatic, but obviously they're going to develop symptoms as the myopathy progresses. Cardiomyopathies are also the leading cause of heart failure besides ischemic coronary disease. So having these cardiomyopathies will lead to heart failure second to ischemic coronary disease. These are the etiologies we'll go through. Genetic issues, extreme stress, that broken heart. We did that with, what's that called again? Remember the name of that? Broken heart syndrome?
I forget the name.
Takotsubo?
Yeah.
Takotsubo? Broken heart syndrome. Pregnancy can do it. Alcohol, remember alcohol is toxic to the myocardium. So chronic alcoholics get cardiomyopathies, hypertension, CAD, any viral infections. Remember one of them has a big link to viral sicknesses before they have the onset of the cardiomyopathy. And some meds can do it as well. So major classifications, we have dilated, we have hypertrophic. That includes obstructive, which is your HOCM. The IHSS is the hypertrophy of the septum, so septal hypertrophy. And you also have non-obstructive. Restrictive cardiomyopathies. And then you have, here's your Takotsubo cardiomyopathy, the broken heart stress cardiomyopathy, or you can have an arrhythmogenic cardiomyopathy as well. These are the ones you'll see the most: restrictive, hypertrophic, and dilated. So here's your normal, here's your dilated one. The chamber size increases. Wall thickness increases as well. Some cases, they can even get thin walls as well. Here's your hypertrophic, obviously very, very, very thickened walls of the heart with your hypertrophic, and then your restrictive. Remember, restrictive, any of those infiltrative diseases, amyloidosis, sarcoidosis, those infiltrative ones cause fibrosis. The heart doesn't work as well. We have filling. Remember, restrictive is filling problems. Just like restrictive lung diseases, they have a problem with volume, not flow. So dilated cardiomyopathy, also known as a congestive cardiomyopathy, most common one. Enlarged hypocontractile heart. What does that mean? Walls don't squeeze very well. Primarily systolic dysfunction due to weakened ventricular contraction. And we get thin ventricles. So dilated cardiomyopathy will cause a systolic a dysfunction. High risk of systemic emboli in these cases. High risk of ventricular arrhythmias. Okay, so sudden cardiac death. Causes idiopathic. These are the bolded ones, are the most common ones: CAD, hypertension, and the alcoholic. Remember, it's toxic to the myocardium. They get a lot of these dilated cardiomyopathies. And any other condition that causes the heart to become weakened or stretched. Okay, when the heart gets stretched, those contractile properties don't line up anymore, and you can't generate the force when they're stretched out. Physical exam findings: shortness of breath, dyspnea. Sounds like heart failure. Remember, this is, again, dilated cardiomyopathies are the most common cause to lead to heart failure besides ischemic heart disease. S3 gallop. Okay, and rails. Mitral regurg may be present if there is LV dilatation. Why do you get mitral regurg with left ventricular dilation?
Pushing back on the valve.
What's happening to the size of the ventricle?
Oh, so it's
like
they
Pulling apart so the leaflets don't touch anymore. because of the dilation. Remember, the valves are attached to the walls, not from the inside. So wherever the walls are, that's how far apart those vessels, the valves are going to be. If left untreated, leads to cor pulmonale. What is cor pulmonale? What kind of heart failure? Right-sided heart failure caused by pulmonary problems. So nothing to do with left-sided heart failure causing the right-sided failure. It's all within the lungs that cause the issue. Biventricular heart failure is common with these patients, so left and right-sided, both of them are weak. But low ejection fraction is the key. Diagnosis, you're going to need an echo on these patients for sure. Shows the 4-chamber enlargement and shows how weak the squeeze is. You can do a cardiac catheterization as well. You're going to see elevated pressures inside the heart, decreased contraction, normal cardiac arteries. This is why you would want to do a cath on this patient, because we want to make sure that the vessels, the coronary vessels, are okay. Because if they're not okay, that could be leading to the issues that they're having. You just stent them, reopen the vessel, and blood flow gets restored. But if the vessels are all clean, then we know it's something that happened to the heart itself. Toxic metabolite from alcohol, long-standing high blood pressure uncontrolled, what is it? But a cath will help. Here's your MUGA. Again, if you want to know what the ejection fractions are, just on the left and right side of the heart. Biopsy, only if there's a treatable cause. So this is what you start, and you go down from there. So you don't want to do a biopsy at first, but you do your cath, so the vessels are clean, they're still having this issue. Let's get a biopsy of the tissue and see if anything's going on that's causing this patient to have all these problems. But again, only if it's a treatable cause. Treatment, because this mimics heart failure, ACE, the ARNIs, the angiotensin receptor blockers, or aldosterone blocker, beta blocker, and your diuretics. So remember, these are the same medicines that you give for chronic heart failure patients. They have the same symptoms. If they have AFib, anticoagulate them, because we know with dilated cardiomyopathies, they're at risk for these systemic and pulmonary emboli. So let's anticoagulate them, reduce the risk of these clots forming, to reduce the risk of stroke or PE. Obviously, avoid alcohol. Makes sense. We know it's toxic to the tissue, so stop it. Dual chamber pacing if you need the resynchronization, meaning the left side of the heart beats before the right, or the right beats before the left, but they don't beat together. When that happens, the heart kind of like rocks in the heart, in the chest. It doesn't just sit there and squeeze. It kind of like will wiggle back and forth because of the way that the walls are squeezing. Obviously, transplant is going to be something you got to think about. Long-term dilated cardiomyopathy, if they're not getting any better, you're on all these medications, they're still not improving with their quality of life, then you start working about other things, transplant possibly as well. Watch for these arrhythmias. They may pop up as well. If they do start getting arrhythmias, then you can just give them an AICD, because the AICD will help protect the patient from those ventricular arrhythmias that are common with dilated cardiomyopathies. So this is just for protection for that patient, these defibrillators. They're not going to cause any treatment, but they're there for protection. Now we're moving on to the hypertrophic cardiomyopathy. This is the most common cause of sudden death in the youngs. Whenever you see these 20-year-olds, athletes dropping dead, they may have had an underlying hypertrophic cardiomyopathy. So you see these athletes on the basketball court and they just fall. Usually it's underlying, this is what the most common causes. Most important predictors are family history of sudden death and recurrent syncope. If you go into a VFib and it may only last 10 seconds, you may pass out from that. In those 10 seconds of very little blood flow leaving the heart because you're fibrillating. So it's a transient. If you're having syncopal events, it may lead to a bigger event that may happen later. Mortality in children with HOCM is twice as high than adults. Hypertrophic cardiomyopathy occurs in heart muscles, and if they enlarge and cause the walls of the ventricles, usually the left ventricle starts to thicken. Despite the thickening, the ventricular size remains normal. So, if the heart is thickening, but the chamber size is remaining the same, how much empty space do you really have for like blood? Not very much. So they have output problems. Nothing can get out. Again, the thickening may block blood flow out of the ventricle. These are called, if it happens, then you call hypertrophic obstructive cardiomyopathy. It's an outflow tract issue. So remember, this is our left ventricle. There's the aorta. This is the outflow tract normally. But in this case, they have a thickened septum and a thickened heart. You see how this outflow tract now is reduced in size because of the thickened septum? This, when the heart squeezes, this septum goes into that outflow tract and it blocks the blood leaving to go out the aorta. Less blood leaves because of this thickened heart, less chamber size, but also this HOCM, it bows into the outflow tract of the aorta. So it causes a subvalvular stenosis. And that's why HOCM sounds like what? When you're listening to the heart, it's going to sound like aortic stenosis. So you have to do some techniques to figure out, is this an hypertrophic obstructive cardiomyopathy, or is it aortic stenosis that's causing this problem to happen? So that's what an outflow tract is. If mild, they may be asymptomatic. Systolic function is usually well maintained. EF is usually good. Mainly diastolic dysfunction of these patients, filling issues. Atrial arrhythmias are common. HOCM is really an old terminology. Now it's this idiopathic hypertrophic septal, but it's a septal thickening. Dynamic left ventricular outflow obstruction. That's what I was drawing in that picture before. At high heart rates, the outflow obstruction becomes more severe because the heart is squeezing more violently and rapid to get the heart rate up. So that septum is really start bowing into that outflow tract, causing issues. That's the dynamic response. Prescription beta blockers and calcium channel blockers to decrease contractility. Yes?
How is systolic function maintained and like ejection fraction if the blood is having a hard time like coming out?
So remember, ejection fraction is a number. Yeah. So if we, normal heart, let's say we fill with 200, but 100 comes out, that's still 50%. But if only 100 goes in and only 50 mLs come out, it's still 50% ejection fraction, just a lower stroke volume. Beware of diuretics. What will a diuretic do to preload in this patient? Decrease it, right? These patients with a decreased preload will put them into a worse heart failure. You can't reduce the preload. They need that support to get the blood out, that pressure there. Only if they have volume overload do you give diuretics. But in a hypertrophic cardiomyopathy, do not give diuretics, and it reduces preload too much. Hypertrophic has an S4 gallop. Heart murmur, holosystolic crescendo, decrescendo. And this one best heard at lower left sternal border. Increases with Valsalva. Decreases with squatting. One of the clues, remember we said a lot of young kids will get HOCM. One of the clues that you can ask a family member is, while this child is out running around with their friends, will they stop and sit down? Because when they squat, it reduces the effect of the hokum, and they feel better. So they'll sit down while they're playing. They'll just sit down and squat and sit down, and they just learn that because when they sit down, it makes them feel better, because it decreases with squatting. So the hokum decreases with squatting. So kids, if you have a white is, oh, they may have hokum. They're sitting down when they actually, are they out of shape or is it something else? Get an echo, and you'll see everything that's going on with that heart. Make sure it's normal. But that could be a simple sign underlying hokum. Again, may be confused with aortic stenosis. So again, how does the Valsalva change? Diagnosis, EKG, abnormal Q waves in inferior and apical leads. May have evidence of LVH. Chest x-ray, increased cardiothoracic ratio. Heart's getting thicker and bigger. It's going to be bigger in the chest. Echo, small LV chamber. So the hole, the chamber size within is decreased because of all the thickened heart muscle. So asymmetrical septal hypertrophy. Parts of that septum are thicker than others. Usually it's going to be 1.3 times the LV posterior wall thickness. It gets a little thicker than that. The LV outflow tract gradient can be measured. Obviously, you need a cardiac catheterization for that to see the pressure changes. And there may be some motion of that mitral valve in a different way than normal because of the way the heart has become thickened. The mitral valve acts funny. Again, the echo report will tell you everything. So just order the echo. Cardiologists, they look at everything, just like how you guys are being trained to do your normal, like Rocky and all that stuff. Cardiologists do the same exact thing every time, so you get the same report every time. Yes?
Why would the chest x-ray be increased? I thought you said the chamber size doesn't, like, actually change.
But the heart becomes thicker, but the size of the chamber and size doesn't change or gets smaller. Like the chamber, like the whole, like when you have like that, this is the chamber size, but now with a thickened heart, it's like that.
Oh, okay. So
But this,
technically
the size is still the same, but the hole in the middle gets smaller.
okay.
So, but it will get a little bit thickened, so you may see a little bit on the sides, some pressure.
So, sorry, so the
Yeah.
actual chamber size would be smaller?
The hole in the middle that holds all the blood is going to be smaller, but the actual, like, if you actually measured the size from wall to wall, the ventricle, it'll be the same. It just thickens and it kind of goes in. EKG changes that you would see with hypertrophic cardiomyopathy. Inferior and lateral dagger-like Q waves. Those are the red lines. Non-specific ST-T wave changes, the green arrows. Why are those non-specific? Which way should that T wave be going?
For which one? They should be down.
What is this one?
ISO.
This is positive. Mainly,
It should
this is
be negative.
taller in the top than it is in the bottom. So this is a mainly positive lead, so T wave should also be positive. Look at this one here. It's the same way here. See how that's weird, like a biphasic? That's a non-specific ST-T wave change with a very, very tall
It should be
R wave. Remember, the R wave is positive, the T wave should be positive. R wave is negative, the T wave should be negative. These are flipped. That's non-specific T wave changes. And the last thing is increased precordial voltage, the blue arrows again, right-sided, increased size. So remember, right ventricular hypertrophy, that as well. Treatment, improving diastolic dysfunction, minimize that outflow tract obstruction. Another goal, maintain normal sinus rhythm. So treatments, beta blockers and calcium channel blockers. Those are the big ones we give. Prolongs diastole, so they're in that filling phase longer with a slower heart rate. Remember, everything is a cycle. If your heart rate is 60 beats per minute, you have 1 second to get everything done. If your heart rate is 90, then you have like less than a second to get everything done, less filling time. So when you lower the heart rate, allows for better filling. Yes?
But if the chamber size is already smaller,
because you're allowing more time for it to fill. When it goes too fast, you have still a smaller chamber, but you still have a time constraint to fill it.
So it just improves it, but does it correct it?
No, but it improves the filling. So remember that this is a diastolic filling problem. We want to improve the filling. So passive ventricular filling, negative inotropes that reduce the stroke force. So we're not going to generate the force anymore, so it relaxes the heart. However, what we're saying there at the end is if you relax the heart too much, you can cause them to go to CHF because now you made the heart too weak and it can't pump anymore. So watch out for signs of CHF with these patients because you may have reduced it too much, made the heart too relaxed, and it caused that problem. Restrictive cardiomyopathies, infiltrative processes, your amyloid, sarcoid, these things, scleroderma, these are infiltrative diseases again. Ventricles of normal size, although the atria can be enlarged. These are filling problems, so the atria is going to be more involved with filling. Remember, the atrial kick helps to fill the ventricles at the end there. EF may be normal or decreased. The primary problem with restrictive cardiomyopathy is diastolic dysfunction. It's a filling problem, so it's volume. And atrial arrhythmias are common. Atrial arrhythmias are common because what chamber size is enlarged in these cases? Atria are enlarged. Anytime you hear anything about atrial enlargement, start thinking about atrial tachycardias. The atria don't like to be stretched. They get irritable. And remember with the heart, any one focus can cause the entire heart to beat. So with these enlarged atria, they can go into atrial tachycardias, most commonly AFib. So S3 is common. AFib may be present. Increased P2, secondary to pulmonary hypertension, and they may have cor pulmonale as well. Diagnosis of restrictive cardiomyopathy, you got to get an echo. So they're going to have abnormal relaxation. Again, that will be listed in the echo report. It will be there from the cardiologist telling you exactly what's going on with the heart. They'll maybe even tell you the diagnosis if they see enough of it in the echo with the history. They may tell you this patient is definitely clearly indicated for this. A glistening pattern, and that's because of the infiltrates that get into the tissue. Increased wall thickness, small ventricular cavities, atrial enlargement. Chest x-ray, cardiomegaly, signs of failure. Watch for that underlying disease. Restrictive cardiomyopathies are usually not by itself. There's usually some underlying cause that leads to that forming. You got to find out what that underlying cause is. We talked about a bunch of them: amyloidosis, scleroderma, sarcoidosis. Start looking at those things to see if those are the culprit for the restrictive cardiomyopathy. This is where you would do a heart biopsy. Because with these restrictive diseases, if you did a heart biopsy, you would see the infiltrates on the sample. You'll see the sarcoid, the fibrosis, the scarring that's occurring on biopsy. That's the only way you'll know it's there. So this is where biopsies are helpful with these restrictive ones. Treatment of the restrictive: prevent or atrial arrhythmias, control that heart rate, treat symptoms of heart failure, diuretics with caution because they're going to reduce the preload too much. These are filling problems, right? Restrictive, so filling. If you reduce the preload, you're going to alter the filling even more and make it worse. So be careful with diuretics in these patients because of the preload reduction. And obviously, any underlying disease they have, make sure you treat it. Arrhythmogenic cardiomyopathy is a genetic problem, and the cardiac muscle are known as desmosomes, and they link these things together. And when they're linked, they have these different proteins. Many of these proteins can have harmful mutations. So this is a genetic cause. 1 in 5,000 people where fibrosis and fat replace the myocardium. So all that muscle is being replaced with fat and fibrosis, the scarring. Mainly the right ventricle, but abnormally enlarged right ventricular size. Most of these patients are young adults as well. So the ages matter. So hypertrophic cardiomyopathy can occur in kids. The dilated one, not so much. Restrictive, young adults, athletes as well. Although a arrhythmogenic one. So evaluation of treatment, first, establish the phenotype. What are their symptoms they're going to be presented with? What is your initial assessment? Do your physical exam. EKG, Holter monitor. Look for any type of VTAC or ventricular escape rhythms. Echo, look at the size of the function of the ventricles. Cardiac MRI will help looking at the tissue of the myocardium. Now they have it. What's the cause and the management? So standard symptomatic management, exercise restriction. Don't have them exercise very much. Beta blockade, antiarrhythmics. They may need an ICD. VT ablation. If they go into VT pretty easily, you do an EP study, find out where this focus is, and you ablate it. And you zap it, and you get rid of the VT. Heart failure management, maybe transplant. Psychological support. That's a big one, especially in people with heart failure, MI, and stuff like that. They get a little dose of mortality and they get depressed. So sometimes you might want to start them on an antidepressant drug, Lexapro, something, while they go through all that. Helps. You can do some genetic testing as well to see any family issues. Anyone else in the family also have it. Functional PET scanning to see where this mass or lesion could be if they have a tumor somewhere. And the last thing is the future. It's cause-oriented treatment. What is the cause of this problem, and you just treat that. So whatever the underlying issue is, gene therapy, anti-inflammatory, whatever it is. Find out what the underlying cause, and you just take care of that. Takotsubo is that broken heart syndrome, stress cardiomyopathy. Mostly older women, sudden stress of death of a loved one. Also can see it in pregnancy. And that's called postpartum or peripartum cardiomyopathy. Takotsubo, etiology, it's affects high cortisol or catecholamines. And that causes an apical ballooning of the walls of the ventricle, so they pop. Chest pain, high cardiac enzymes. So you think they're having a heart attack. They come in, they have chest pain. Their enzymes are high. Okay, they're having a STEMI. Wall motion abnormalities, but you do a cath and everything is normal. All the vessels are fine. There's no ischemia at all. Nothing leading to blocked arteries. How much does an artery have to be blocked before you start getting chest pain at rest? High percentage, right? 90%. So they don't have any blockages at all. Nothing that causes them to have this chest pain. You do a history, they had a loved one pass away, Takotsubo, now they have this broken heart syndrome. Yes?
Could something like Cushing's disease with high cortisol cause symptoms?
Yeah, so this is that apical ballooning. See how it pops in and closes off? So less blood comes out. It's almost like an outflow tract obstruction. But this ballooning right here, this little compression, reduces the blood coming out. And it resembles that's why it's called Takotsubo, because a Japanese octopus pot. That's how it looks like the heart chamber size. And we're done with this one. Okay. This one's short, and we'll be done. What time is it? Okay. You want to do it on Monday? Yeah. Okay, we'll do it Monday. It's a short lecture. We'll do it Monday, we'll do a review.